We'll begin to feel that discomfort and pain. Almost below the xiphoid process, and not exactly in that area, but it's not really high up. They may feel a little bit of burning and sensation, way up into their esophagus, but the main place they're going to see that is around their right where that stomach connects there to the esophagus. All right. Okay, so hiatal hernia, it's about 50% incident is a common around older adults. About 50% of the people that have a hiatal hernia are older adults, and it is more common in women. Something good to remember as well. By the way, there is a nursing care plan there that's a short little one-pager. It's on page 300. So just be sure you take a look at it. It talks about a patient with pain with hiatal hernia and some of the nursing actions that you might want to suggest or do for your patient. So those little care plans are really, really good in this textbook. They're concise. They give you exactly what kind of nursing actions. And if you're developing a plan of care, maybe if you're out there in Gero and you have a patient that has GERD or has a hiatal hernia, be sure you're looking at the care plans in this book to kind of give you some suggestions along with your ACLY book. All right, so again, 50% is with the older adults, and it's most common with women. Dietary fiber is low fiber. This is someone who does not take in a lot of dietary fiber, and excessive calorie intake that results in obesity tend to have hiatal hernias. And so what are the symptoms in a hiatal hernia? Well, let's see. Very similar to GERD. However, you would have heartburn, dysphagia, problems with your swallowing, belching, a lot of burping, vomiting, and even some regurgitation is common to these patients. And the patients with a hiatal hernia do present pretty often with epigastric pain and sometimes chest pain. And sometimes the patients and even the doctors, until they do all their EKGs and those things, mistake it for a heart attack. And some bleeding may occur as well. So that's something to kind of keep in mind. So the only diagnosis really that they're able to do to confirm the presence of a hiatal hernia is a barium swallow or esophagoscopy. In other words, going down and looking into the esophagus to kind of see that. So let's talk about some of the treatments. Well, if the patient is obese, because we know that is more prevalent in the obese patient, we want to talk to them about weight reduction. We want to use a bland diet, and obviously that's the kind of diet in which there's not a lot of spices, like burning. Some foods such as tomatoes, we would definitely want to decrease the amount of tomatoes that they eat, because those are like acidic citrus fruits. Things of that nature are not included in a bland diet. They may have to take some antacids. However, remember with your antacids, depending on which ones they take, like Tums, which is calcium carbonate, if they take these antacids, we have to be sure to make sure that they're following the directions, because they can develop hypercalcemia if they take too many of those antacids with calcium carbonate in it. So again, that works for them. As far as a diet, it's much better for the patient to have like 6 small meals a day instead of 1 or 3 large meals a day. It's much better for them, and they can digest it a little bit more. We don't want them to eat right before going to bed, obviously, because it can cause an increase in reflux and discomfort from this hiatal hernia. And we might want to ask them to be sure that they're elevating themselves in the bed when they're lying down instead of not lying flat. They want to be sure they're up on multiple pillows, so there is no chance of GERD to occur and cause a lot of problems with this hernia. We always teach them about their medications, and if they're on, they could be on proton pump inhibitors, H2 blockers. And if they are, we always teach them about the purpose of those medications and how to take them. For instance, reduction of acid and reflux. They need to know why they take these medications in common language. So it would encourage them or empower them to take those medicines as they need. So hiatal hernia, very common. 50% of the people that have this is usually older adults and predominantly in women. Let's talk a little about esophageal cancer. We won't spend too much time on esophageal cancer, but there's different types of esophageal cancer. We mentioned Barrett's last week when we were talking about GERD, but there are many causes of this particular type of cancer. I've seen esophageal cancer. I worked in oncology for many, many years as an oncology nurse, and we had quite a few patients with esophageal cancer. The majority of those patients drank a lot of alcohol. They also smoked heavily. And so some of that, and of course, because of that, they didn't eat proper. And so, you know, that malnutrition state that many of them had, there was an incident of esophageal cancer. Chronic irritation in the esophagus from, for instance, alcohol. You know, alcohol can burn the esophagus. Reflux, that's really, really, really bad, and that acid is constantly burning the lower esophagus, can also maybe contribute to the development of esophageal cancer. There is a higher incident in men, and as I mentioned, alcohol, poor oral hygiene, and smoking, all of those help to contribute to the development of esophageal cancer. Signs and symptoms, of course, is drooling, weight loss because they're not eating very well, and they hurt when they eat. Sometimes they can bleed. The other problem with esophageal cancer is what we call esophageal varices. I imagine you have heard about that before. Esophageal varices really are things that we can't do a whole lot for in most cases. I had a patient on my oncology floor who had esophageal cancer, but they also had esophageal varices. And one night, I worked the night shift in many of my younger days in oncology. And I remember the nurses, and we were sitting at the nurse's desk, and we heard a patient coming up the hallway. You know, the lights were kind of dim. We tried to keep the lights dim. And we heard this kind of gurgly kind of sound. And of course, we all stood up because we didn't know what was going on. And here comes this patient coming down the hallway, holding his hands over his mouth like this. Blood was pouring out of his mouth. What had happened, his esophageal varices had ruptured and he bled to death. We couldn't save him. So these are very dangerous things to have, but it does happen. And even a little bit of bleeding, we need to be paying close attention. If a patient is having bleeding, coughing up blood, it could either be from the esophagus or the lungs. So it needs to be addressed, obviously. Okay. Hiccups is also another issue. I had an HIV patient who had intractable hiccups. In other words, he would always hiccup, and he had cancer as well. And so we gave him, I think it was Thorazine, to try to calm his hiccups, because it's almost like constant, because it's an innervation of the vagus nerve there. And of course, they're thirsty a lot. So the diagnosis for this is a barium swallow and doing an endo with a biopsy. You know, that's what the healthcare providers would do it. Okay. On a Barrett's esophagus, I just wanted to remind you of this, is that the lining that is in the esophagus, because it's so close to the stomach, is actually going to be replaced by what we call intestinal lining, what appears inside the intestines, which is at an increase, that causes an increased risk of cancer. That's why we see that there's a change in the layers of the endothelial layers of the esophagus. So that increases the development of esophageal cancer. Benign tumors are rare. So if somebody is diagnosed with esophageal lesions, particularly Barrett's, then it's going to be rare that it's going to be benign. So esophageal cancer is definitely an issue. Generally, you know, with cancers, and especially with esophageal cancer, it comes over slow periods of time. So for instance, the gentleman that I mentioned to you who had died from bleeding out from the esophageal varices, I mean, he was a heavy drinker, a heavy smoker. He did it for like 20, 30 years. And so that over time, you know, that's what causes, and sometimes that cancer is not noticed until it's a little bit too late, or those esophageal varices. So let's talk about peptic ulcer disease. It is thought to be from stress, diet, even genetic factors can be part of the development of peptic ulcer diseases. And sometimes if there is a complication from COPD, that can lead to peptic ulcers disease. So the other thing to remember about this is that there's something called Helicobacter pylori infections. So if somebody's having some gastric distress and they decide to go into the stomach and take a look, and they find this particular bacteria, which is curable, I mean, it can be, they can give them antibiotics. We have to be very noticeable to making sure they'll be looking closer to make sure there is no ulcers in the stomach, because when you see this pylori bacteria, there is a potential for that these peptic ulcers have started to grow in them. So this dietary factors, of course, again, is lots of caffeine and alcohol. Anything that's going to be irritating to the stomach lining can cause peptic ulcer. And you know, with stress, there's the release of epinephrine and norepinephrine, and you know what the stress response does. It increases all kinds of things. The hydrochloric acid increases, and so it can cause a lot of issues with the stomach, as well as the rest of the body as well. Okay. Older adults have some really acuteness to their pain, bleeding. Sometimes there's obstruction in the stomach. Sometimes there's perforation. And someone with a perforated stomach doesn't do very well, right? It's really difficult to treat once it has perforated. So the symptoms you might see are, for instance, anemia. Why do you think anemia might be a symptom of peptic ulcer disease?
They're bleeding in the GI tract.
Yes, there could be some hidden blood. Now, the other thing, what else would you be assessing if they're anemic? On the other end of the body, what are you going to assess?
Their stool.
Yes. What color should the stool be? Or, I mean, what color would it be if they did have this disease?
Well, I was like, normally, or?
I mean, well, normally it could be a lot of different things, right? Green, purple, depending on what they eat. But what color would the stool be potentially if they're bleeding from a peptic ulcer?
Peptic ulcer. Isn't it dark black?
Yes, very dark stool, absolutely. Now remember that if it's closer in the colon or the rectal area, it's going to be a little bit more red because the blood is fairly fresh. So if you start seeing that and they're having all these different problems and they are anemic, you've looked at the H&H on the patient, and they've got some Helicobacter pylori infection, pretty much they're probably going to have a peptic ulcer. There are some complications to this particular condition. Constipation, diarrhea can be caused actually by an acid therapy, right? And pyloric obstruction is a serious problem. In other words, where the pyloric valve becomes obstructed, the patient can dehydrate, they can develop peritonitis, which is also very serious. They wind up in the hospital, with massive doses of antibiotics and things. Of course, hemorrhaging and shock. Lots of things can happen to someone who has a peptic ulcer, and particularly if it perforates. So what would we do as a nurse? Well, you can do a lot of things, but making sure you're going to be looking at those medications. And in this case, the reason we look at the medications, we want to look at the medications that either increase gastric secretions or reduce the resistance of gastric mucosa. In other words, like aspirin, for instance, that increases the potential for burning in the stomach. We know that. Corticosteroids, tolbutamide, and some others. So we want to be sure we're looking at the medications to see if they are affecting this patient's GI tract. We always do the education on heavy smoking, decrease caffeine, because you remember caffeine increases the acid production in the person and causes an increase in discomfort and pain. There are smoking cessation programs, obviously, that we can refer them to. Also, if there's a lot of stress in their lives, you've heard the story where people are type A personalities and they always have stomach pains, they always have ulcers because they're just go, in their high stress jobs, or just a high stressed individual. So we want to kind of find out what's going on in their life so you can actually assess their patterns of lifestyle and what's going on. We can teach relaxation techniques to try to help reduce some of that stress management. And of course, if they do have the Helicobacter pylori infection, we want to teach them all about their antibiotics and making sure that they take all of them as prescribed, either 7 to 10 days, whatever has been prescribed. Because if they don't, what could happen. It won't be killed completely, and then they'll colonize again and they'll start growing again. Because sometimes people, as you remember from your pharmacology, they tend to feel better after a few days, and so they quit taking the antibiotics and they say, oh, I'm going to save them for later. How many times I have heard this in my practice? Yeah, well, I only took them for 3 or 4 days because I started feeling better, and they're in my cupboard now because if I get sick again, I'm going to take them. So we have to be sure that we are doing a lot of education for these patients with peptic ulcer disease. Of course, cancer of the stomach can happen as well. It does increase with age, mostly in men for this one, whereas your hiatal hernia is women. For cancer of the stomach, it's men. Low or poor socioeconomic groups also have a tendency to develop a high incidence of cancer of the stomach. And remember, a lot of this is affected by the nutritional status, the amount of cigarettes they're smoking, the types of things they're drinking, alcohol, liquor, whatever it might be. And so not eating properly because they're poor, homeless. When I was working in one oncology unit, many of our patients were patients from the very, very poor community, and many of them were homeless. So we had a lot of examples of very, very ill patients with cancer of the stomach, the esophagus, pancreatitis, which led to cancer of the pancreas. And so because of their living environment as well. So there are signs and symptoms, of course, pain, weight loss, anemia. Even an enlarged liver can be a sign of cancer of the stomach. The only treatment truly is surgical for this. They can do some chemotherapy, but they have to get rid of the cancer that's in the stomach. And many times by the time cancer is diagnosed in a stomach, remember, because usually initially a cancer is painless. By the time it's diagnosed, it most likely has metastasized, and the first place it's going to be going to is the pancreas, the liver, anywhere that's close by, right? The prevention for cancer of the stomach, of course, is eating a healthy meal, not a lot of red meat. Um, Keep that diet low in red meat, and of course, lots of fruits and vegetables that have high antioxidants. And there's lots of foods, but again, for the poor economic or poor socioeconomic group, remember the fruits and vegetables and the healthy meats like chicken and turkey and things are more expensive. And so they may not get a proper diet. That's cancer of the stomach. How about diverticular disease? It is common in Western societies. It's rare in third world countries. Isn't that interesting? It's rare in third world countries. So let's look at the differences between diverticulosis and diverticulitis. In diverticulosis, bowel content or the stool kind of accumulates in the diverticulum, and they begin to decompose, causing lots of issues within the intestinal tract. Diverticulitis, however, is inflammation, the itis meaning inflammation. We mostly find diverticulosis in the sigmoid colon. That's where that's usually located. So here we have multiple areas within that sigmoid colon and the intestinal mucosa. It's got little pouches. It weakens the muscular walls of the large bowel, so things are weakened. The thing is that many people are asymptomatic, but actually have this pathology in the sigmoid colon. So they don't even realize they have diverticular disease until perhaps maybe they get a colonoscopy and they say, oh, by the way, all right. So there is some causes. Low fiber, low residue foods, because remember, we need that high fiber to help us to empty our bowels regularly. The common symptoms that present would be things like chronic constipation, obesity, even that hiatal hernia. Remember, based on aging changes, that the intestinal wall becomes smaller, it atrophies. Remember, it's muscle, so we know that muscle atrophies in the older population. Abrupt onset of pain in the left lower quadrant, nausea, vomiting, of course, there's that constipation, diarrhea, a low-grade fever, and blood or mucus in the stool can be symptoms of diverticular disease. And again, the progression of this particular disease is fairly slow, and the onset may just be immediately and acute. They may not even have it, think there's got a problem, then all of a sudden, bam, they get these severe pains. So for nursing interventions, during the acute episodes, we need our patients to rest. We need to make sure that we give them the IV fluids that they need and they have been ordered, and of course, antibiotics, because they want to reduce the infection. Because remember, when all of this stool gets stuck in the diverticulum, or the diverticula, I should say, LA, it starts to degrade and infection can result. So we're definitely going to have to put these patients on antibiotics and some fluid as well. Of course, we'll do our pain assessment, give pain medications, because it will hurt once it becomes an acute condition. We're going to do some teaching, of course. We're going to teach our patient about, at this point, we're going to consume a low residual diet. The reason for that at this point is that we want them to rest their bowel. We don't want them to eat a lot of food. And sometimes even the doctors in the hospital will put a patient NPO for a while, particularly in the acute phase of this condition. We also want to make sure that we're teaching them about the signs and symptoms of a flare-up, like nausea and diarrhea and bloody stools. And they need to be informed that this is a chronic condition. and will probably need to be monitored frequently and be taken care of, because remember, it takes a while for this to develop and it's going to continue to happen. All right. All right. So overeating, straining during a bowel movement, alcohol, and irritating foods may contribute to diverticulitis in the patient with diverticulosis. And the answer is true. Absolutely. All of these things can contribute to infection or inflammation, I should say, diverticulitis. Okay, let's take a look at colorectal cancer. It's the second most common malignancy in the United States. The symptoms we might see are rectal bleeding, bloody stools, changes in the bowel patterns of the patient if they've been normally having good bowel movements and then all of a sudden they're having some difficulty. Sometimes they feel that they have not emptied their bowels. They have a bowel movement and then they go, oh, I feel like I still have a lot more up there. So that's a feeling, because it could be a lesion that's causing that feeling of fullness. Of course, nausea is very typical, anorexia, pain over the area of where the cancer is located. The patient is going to be weak and fatigued, obviously, because number one, if they're losing blood, they're losing their iron, which they need, and the nutrients, and so it's going to cause them to be tired and to make them weak. And if a patient has unexplained weight loss, that could be a sign of, unfortunately, an advanced form of colorectal cancer. Once we start losing weight, then we got some issues going on here. And I've already mentioned anemia. How do they diagnose this? Obviously, as the colonoscopy and a fecal occult blood test. Yeah, hopefully y'all remember that fecal occult blood test, where we use the two little cards, or actually the patient nowadays, there's new ways of doing it. Actually, now the patient can send in stool samples to the lab. You know, they get this little packet of, and then they can send stool specimens into the lab. They check for bleeding in the lab. We can also use the little cards, which is the fecal occult blood test that we use, where we get pieces of stool from different areas in the stool, not the same area, but different stool areas. And there's two places to put it on the card. We close that side of that little card, we turn it over, and then we drop the developer on there. And if it turns blue, then it means there is some occult blood in the stool. So you may have to do this in the hospital. What we're seeing now is a lot of times stool samples go to the lab, and they do a lot of that in the laboratory now. But if you're working in a clinic, you may have to send a patient home with this kit and have them send it over to the laboratory for analysis. With colorectal cancer, it's a huge piece. I used to work on a colorectal floor, and there's lots and lots of patients that came in with not just cancer, but diverticulitis, Crohn's disease, and some of those others. But resectioning of the bowel, sometimes they wound up with temporary colostomy. Sometimes they had permanent colostomies, depending on how intensive that the cancer was. So we also have to think about the impact of that colostomy on an adult patient, particularly an older adult patient. If they have to have one, we have to do a loss of assessment to see if the patient can even change their own colostomy bag. Because remember that now you're starting to look at the age of changes. We're going to make sure that they have the dexterity to be able to change their dressing or to change their bags, to take care of themselves at home. With the older adult, we definitely do a lot of assessment, physical assessments on our patient and cognitive assessments to make sure that they're able to care for themselves. So that definitely will be an impact on that older adult. All right, so I want to check your critical thinking here. All right, so let's see who would like. Heather. Where's Heather?
I'm right here.
Hey, Heather. Could you read this? Yeah, and then read the progress note, and then let's see what kind of responses you might want to select.
Okay. Client states, oh, a nurse is caring for a client with advanced cancer. After reading the nursing note below, okay. Client states the doctor says my chemotherapy isn't working anymore. They can only treat my symptoms now. I don't want to die in the hospital. I want to be in my own bed.
Okay, Heather, go ahead and read the responses.
Okay, number one, reread the document on client's rights to the client. Number two, call the client's spouse to discuss the client's statement. Number three, tell the client that only in the hospital can there be adequate pain relief. Or number four, explain the use of an advance directive to express the client's wishes.
Okay. So what would you think would be the best response to your patient?
Not read. Not to. Either one or four, but I forget if for number four, if the nurse is allowed to like just explain advance directives, or if the physician like has to do all of that. So I'm not sure. Can I tag a friend?
You can certainly call on a friend.
Okay. Hendrick. What do you think? Okay, what about Alexis?
So I would explain the use of advanced directives to express the client's wishes, because I mean, you're not having them like sign anything.
Okay, does the class agree? Anybody disagree?
I would say that too. I would pick 4.
All right, well, let's take a look. You are right. Yay, very good. Yes, that is true. Of course, we can explain a lot of this stuff to our patients, but you're right. If they're going to sign advance directives, we usually have business office come and take care of that. But as nurses, you know what an advance directive is, and you can explain it. Oh, number one, and I know, Heather, that you said you were between 1 and 4. Let's go back and look at number 1. It says to reread the document on client rights to the client. Class, why do you think that is incorrect?
Would that be because there was no discussion about the document? It was more of client stating he wasn't referring to a document?
Okay, that's kind of close, Uma. That's a good thing to think about. However, does it address the client's actual concern?
No, it's not.
It's not even addressing the concern of the client. And rereading a document on client rights will really won't say much, will it, to your patient? So we would not want to do that, because we want to address the problem. And the only one here that is the best answer would be explain the use of the advance directive. And I like, Heather, that you said, oh, let's eliminate 2 and 3. Okay. We'll call the client spouses to discuss the client statements. Why did you not choose that? Can anyone think of a reason? Go ahead, Heather.
For why did I not choose number 1?
Number 2.
Oh, number 2. Okay. Because that would like be a violation of HIPAA.
It's what? I'm sorry, I misunderstood you. What did you say?
That would be a violation of HIPAA.
Okay, true. But the most important thing is what? There is nothing to indicate in the question or the statement that this patient is incompetent. So that's really the true reason you would not accept this one. Because there was no indication, and we don't add anything or subtract anything from a situation. In this case, it would not be acceptable. And you're right about the HIPAA violation. And of course, I think everybody can tell in number 3 that that's definitely false. That there's lots of ways that pain relief can occur at home, at hospice, or some other type of community area. So very good. So y'all did a good job on critical thinking. Thank you, Heather, for working with that with us. Okay, chronic constipation is also very common in the older adult population, generally because of the inactive lifestyle, low fiber diets, not a lot of fluid. Because remember, here we go, we're thinking of all those changes in the older adult. They don't drink as much fluid. Sometimes they get depressed, particularly when they don't get out, when they don't have people to visit them or family and friends. There is some patients that have laxative abuse. The more laxatives that we take, the stimulant, because remember the bowels can be stimulated, and we can do bowel training. Now we can tell our bowel, you're going to go to the bathroom every morning at 6 o'clock. But the more we do take laxatives, the bowel kind of thinks that, oh, I can't have a bowel movement until I get stimulated by this substance. I mean, that's kind of, if you put it in living terms, that's kind of what they see. So laxative abuse is a problem because once they stop taking the laxatives, they're going to have chronic constipation. Of course, many of our patients, again, there's that polypharmacy again, multiple medications, particularly pain medications, can cause that constipation. Sometimes they give them sedatives depending on their condition. For dementia patients or Parkinson's disease, there's a lot of chronic constipation in those patients. All right. Aluminum hydroxide also can cause constipation. And of course, all this is kind of, we think about the sensations. Remember, there's a decrease in the neurological firing mechanism in all the little nerves. And because of that, the sensations to the bowel are dulled or reduced. And so that's one of the reasons chronic constipation is a major issue for our older adult population. So some of the symptoms that you can probably imagine: dry, hard stools, they can't get rid of them, they can't eliminate them. Abdominal distension. The patient history, when you take your patient history, you discover that they don't move around very much. They have very little activity. Their diet is high in carbohydrates and very little fiber. That they don't feel thirsty a lot, so they don't drink, a lot of water. And of course, then you're looking also at their medications, their mental status, and are they taking laxatives at home? And so lots of things can cause and help us to determine that a patient has this type of problem. And with the older adult, it's really, remember that constipation or chronic constipation, is really a symptom. But with older adults, it's more of a health concern. Right? So these are just really kind of symptoms. So one of the best diagnoses, of course, is to do a rectal examination, a digital examination to see if that hard stool is up there. So what can we do as nurses? Well, a few things. Well, we can help them with some kind of physical activity plan. We can teach them all about fiber and why they need to drink increased amounts of water. Talk about the foods. Be sure you know the types of foods that are high diet. high fiber foods for helping with constipation. If the patient is using a lot of laxatives, we need to talk about it. It's particularly because many laxatives, as you know, are over the counter now. All right. We talk about what other things they're taking. Are they taking those particular medications that's going to cause them to have constipation? We need to talk about that as well with our patients. We also want to encourage them, as soon as they have the slightest urge to go to the bathroom, they need to get to the toilet. The more we do that, the more the bowels will relearn that they need to go ahead and have a bowel movement. And they need time to relax and to have that bowel movement. Sometimes in long-term care facilities, I've seen this, and even in the hospital, I've seen it, where an older patient has to have a bowel movement and they kind of get rushed. You need to hurry up, or, not that you say that, but you kind of like, okay, come on, let's do it. But really, these patients need to have sufficient time to relax and to empty their bowels completely. They also need to think about having a regular time for bowel movement. And like I mentioned, we can train our bowels. If not everyone, remember, having a bowel movement is individualized, because some people can have a bowel movement 3 times a week. Some people can have a bowel movement every day. But whatever the time is, it's always good to try to train the bowel to go every morning after breakfast, or whenever the patient is more comfortable. And then after a while, the bowel will remember. And so it makes it much easier for them to decrease this problem with constipation. We talked about laxatives, and of course, the laxative abuse also can cause diarrhea. Lots of laxatives, and then of course that can segue over to dehydration. And of course, now you're thinking, okay, dehydration, electrolyte imbalances. What are the signs and symptoms of electrolyte imbalances? Is a patient dizzy? Now we're talking about fall risk. Their mentation will change with dehydration. So one thing leads to another, and you're able to come up with all kinds of nursing interventions and actions for chronic constipation. This is a real big one, I think, in this older population. All right. Well, we have flatulence. Sometimes our foods, we know that cabbage and onions and foods such as that will cause a lot of gas or flatulence. And if the flatus cannot be expelled, that is going to cause some severe discomfort in the abdomen. And if you've ever had gas pains, we call them gas pains, they can be almost excruciating. And so for our patients, it can be the same thing. Activity increases the ability of the intestines to release that gas. Changing positions on our patients. Sometimes when they stand up or they roll over, they'll pass gas. And a lot of times it's because the sphincters, the external internal sphincters of the anus are weakened, and weakened for, maybe for aging changes. Maybe they had rectal surgery at one time in their life. Remember, the more surgery we have on our muscles, the weaker those muscles get. And so maybe that's one reason they can't hold their stool, or maybe that's one reason that they pass gas every time they move. So again, for management and treatment, on occasion I've seen that we use what we call flatus bags. In other words, it's we can put a rectal tube in, and that will help release some of that gas. But the best thing really is physical activity to help that patient release that gas. And there's medications over the counter like Gas-X, simethicone, so we would want to make sure that that the healthcare provider is okay with that particular medication. All right. Intestinal obstruction can be caused from many, many things: adhesions, hernias, tumors, of course, and ileus. And when I worked on the colon floor, we had many, many patients who had, say, had abdominal surgery. 4 or 5 years later, they're coming back because they now have intestinal obstruction. Because there's adhesions, after surgery, the tissue that forms is generally scar tissue, and it can cause adhesions and will cause some strictures inside the bowel or on the bowel or against the bowel. And so we call that obstruction. In the large intestine, it could be from cancer, and small intestine, it can also have some adhesions as well. Now, of course, the signs and symptoms for intestinal obstruction, as you remember or recall from med-surg, could be a lot of things: distended stomach, inability to either pass gas or to have a bowel movement, worst case scenario, nausea and vomiting, lots of things. And then when they do the KUB, which is the kidney, ureter, bladder x-rays and ultrasounds, they might be able to see the obstruction. So lots of different signs and symptoms, but it also depends on where the obstruction is occurring. And I know that you know about NG tubes, and sometimes we have to actually insert an NG tube in order to assist with this intestinal obstruction. Important to remember is how to do bowel sounds. Where do we start to assess bowel sounds? In what part of the abdomen?
Right lower quadrant.
Right lower quad. Then you move up to the right upper quad. Go over on the transverse, you're crossing over, which is the transverse intestinal piece. Then you'll be listening on the left upper quad, and then go down to the left lower quad, which is around the sigmoid colon. Remember, always do that. So remember, there are 4 pieces. We have an inspection, auscultation, percussion, and palpation. So which of those are you going to do first? Rebecca, did you say inspections? Yeah, I can't hear you, but I saw your lip thread. Yeah, hey, that's pretty good. Yeah. All right, great. Yes, you're always going to inspect first, because if you go and touch your patient's abdomen, then it's going to cause peristalsis to increase. So be sure you're doing it really, really, really good. How long are you to listening in each quad if you don't hear anything?
Five minutes.
5 minutes, absolutely. Only on a few occasions in my career have I had to get another nurse to listen. There's been a couple of times that I cannot hear anything. And so I would call the nurse, and only on like one occasion, and of course it's kind of rare, neither one of us heard anything. So that means this patient was obstructed, and of course it was a medical emergency. It doesn't happen a lot, but we still need to be documenting that. There's hypo sounds, there's hyper sounds. Remember, it's like 3 to 30 sounds, but we don't count the sounds anymore. What we do is we listen to it. If it's really, really slow, it's going to be hypo. If it's real fast, tinkling sound, it's going to be more of a hyper sound. And so you have to be able to identify whether it's hypo or hyper sound. Okay. So here's a question for you. So with someone who has a new onset of a bowel obstruction, what type of bowel sounds would you hear? Would you hear hypoactive, high-pitched, absence, or presence of limited bowel sounds? If it's a new onset, if it just started,
Hypoactive because it's not completely obstructed yet.
okay, potentially, but what we normally hear, if it's a brand new obstruction, we're going to hear very high-pitched sounds because the obstruction is not fully confirmed yet, and the liquid through the intestines is trying to come, and so it's causing a high-pitched tinkling sound. So that's what we would see. Now, if the obstruction has been there for, say, a long time, multiple days, then that's when we might hear an absent bowel sound. So by the time we get the patient to the hospital, they've been going through several days of abdominal discomfort. They their abdomen is distending. They can't have a bowel movement, and now they're starting to feel nauseated and miserable. By the time they get to us in the hospital, this is usually what happens, we start hearing absent bowel sounds, particularly if it has been multiple days before they've come in. But initially, if you hear really high-pitched, really squealy kind of bowel sounds, that means the obstruction is occurring and it has not quite completely compressed, and it's squeezing through the little space in the intestinal area. So that's why we hear high-pitched. Okay, good. All right. So high-pitched is the correct answer. B. All right, we'll take a break in just a moment or two. Oh, actually, oh, this is a good one. We're going to take a break now because when we come back, you have 8 choices to select all that apply. 8 choices from this clinical judgment. You're going to develop your clinical judgment. So it's 9:54. So let's come back here. Let's see, 54, 50, okay, 54, 4. Come back at 10 after, right? That gives you too much. It gives you 15 minutes. 10 after is fine. That'll give you 15 minutes because I want your mind fresh, because when we come back, you're going to read this and then you're going to choose your responses based on this patient. All right, I'll see you back here at 10 after.
Thank you.
Uh-huh. All right, class, it's 10 after. Welcome back. All right. Hello, hello. All right, what I want to do, I'm going to call on someone to read this, and then we're going to talk about this scenario. And then we will go over to the responses. So let's see, Steve. Are you there?
A 68-year-old client's being seen for follow-up wound care on her right lower leg. During the visit, the client states she hasn't had a BM since her last visit a week ago. Client states she hasn't had much of an appetite in the past few days and says, "Figure I don't have anything in there to come out." The nurse auscultates the client's abdomen and hears hyperactive, high-pitched bowel sounds in the upper left quadrant and hypoactive bowel sounds in the lower left quadrant. The nurse collaborates with the healthcare provider, and the client is directly admitted to the hospital for possible intestinal obstruction. Before going to the hospital, the client asks the nurse what to expect. Which statement by the nurse is most likely accurate? Select all that apply.
All right, very good. So let's talk about this little scenario here. So first thing, what's happening to this patient? We think it's an intestinal obstruction, correct? So why, and the question to you, and Stephen, you can answer as well. If the patient is got hyperactive, high-pitched bowel sounds in the upper left quad and hypoactive in the lower left quad, why are we seeing hypoactive lower left quad?
Because it's distal to the obstruction.
Yes, because the obstruction is up in the upper left and it's trying to get through, and so it's making all that racket trying to get through, and so it's the lower part of the bowel is just kind of waiting for the fluid or the stool to come through, and so it becomes more hypoactive. So I'm going to leave, well, let me see, let me put this up. So here's your statement. So the question is, which statement by the nurse is most likely accurate? And the client is asking the patient what? Anyone? What's the client asking the nurse?
She wants to know what to expect when she gets in the hospital.
Yeah, what's going to happen? All right, so I'm going to give, yeah, what's going to happen in the hospital? So go ahead and take a couple of minutes or so if you haven't already, and take a look at each one of these and have in your mind what you think is going to happen in the hospital. I'll give you about a minute. Have you gotten your answers ready, class?
Do you want me to read it?
Okay, I'm gonna read because there's a reason. Hang on just a sec. Okay.
I mean, do you want me to give the answers?
Oh, no, not yet. No answers yet. Okay, hopefully everybody has had an opportunity to decide what's going to be the correct answers. So let's look at the first one. All right, Grace, read that one. I'll let Grace read this one.
Number one, an abdominal x-ray will determine if you have an intestinal obstruction. I believe that is true, so I would mark that as 1.
Okay. Did everybody get that right? Okay.
Yep.
All right. Number 2, Kiyomi.
A nasogastric tube will be placed to relieve intestinal obstruction. I said true.
Okay. All right, why do you say true?
Well, I remember it said that she had high-pitched sounds, so I remember that that's like the beginning of a new obstruction. So
Okay.
I just went with nasogastric tube.
All righty. Let's see, Anne Marie, how about number 3?
Surgery would be necessary to remove any obstruction. I don't believe that should be stated right away, especially if like we're not completely sure of that, but she should be aware that it might be an option.
Okay, number 3, thank you. All right, Leland, number 4.
You will not be able to get out of bed while hospitalized. Yeah, I'm not feeling that one so much because we want them to get up and walk around so they don't get any blood clots.
All righty. Let's see who else we have here. Mai.
Number 4, number 5, you should expect to stay in the hospital for a lengthy amount of time. I wouldn't choose this because yeah, like we want to get them up and moving as soon as possible, like ambulate as soon as possible. So I wouldn't choose this.
Okay. All right, good. Vivian, number 6. Are you there, Vivian? Okay, I don't hear Vivian. All right, Logan.
You should drink lots of water to help move the stool out of your body. I would say yes for that one.
All right, let's see, one other person. Michael.
Did we do 6?
Did we do 6? Oh no, I think we missed
Oh,
it.
no, I must have skipped over it.
That's okay. We did number 7 though. Okay, number 6. Go ahead, Michael.
You replaced on a mechanical soft diet. I'm thinking because I would figure she'd be placed on a liquid diet first. I would say nah. I'd probably leave that out for now.
Okay. All right. And number 8, Mira. Are you there, Mira? Okay. Stacy?
Which one? There's 2.
I'm sorry. Yeah, I think we're actually on number 8.
No, there's 2 Stacy's.
Oh, I'm sorry. I'm sorry. Matthew.
Number 8, diarrhea is a sign you are passing stool adequately. I don't think that's true.
Okay. All right. All right, so now let's go back to Steve. All right, Steve, you're going to break the tie here. What is your answers?
Wait a second, it said 8. Oh, so just repeat what the answers are?
No, just give me the answers that you choose.
Oh, the answers that I choose, an abdominal x-ray will determine if you have an obstruction. An NG tube is going to be placed to relieve pressure. Surgery may be necessary, so that's not an answer. You will be able to get out of bed because we do want them mobilizing. It'll help move the intestines also, besides stopping DVT. We don't know how long they're going to stay in the hospital. Hopefully it's a short stay, 3 days, who knows? But that's more likely than a lengthy amount of time, so I would not include that. Being placed, I don't think she'll be placed on a mechanical soft diet because she's on an NG tube. So I think she'll be getting NG tube feedings. And then since she's NPO, after being NPO, you start a patient first on liquids and then slowly move them up. So she may be placed on a mechanical soft diet at some point before she's discharged. So that may be possible. She'll be definitely drinking lots of water to help move stool out of the body. And now diarrhea isn't a sign that she's passing stool adequately. Adequately, we would want firm stool, but diarrhea may occur initially.
Okay, so what numbers are you going to choose as your response for this patient going in for intestinal obstruction?
1, 2, 4, and 7.
All right. Class, y'all ready to get the answers?
Ready, Freddie.
You're ready. All right. Did y'all get 100? That's it. 1 and 2 are the only correct answers for this scenario. So let's talk about the ones that were not acceptable. And I think everybody understood number 3. We can't say that. Remember, the patient is going in for an intestinal obstruction, and the patient is asking, what's going to happen to me? Well, we don't really know if it's going to be necessary. So obviously you're going to eliminate that one. I think everyone agreed that number 4 was definitely not something that we're going to do because we want them to move around, right? Most of you, I think it sounded like you did number 5 and said, oh no, that's not going to happen. We want it to be a short stay, all right? Number 6, there was some controversy with number 6 and number 7. If the patient is going in for an intestinal obstruction, you realize they're going to be on a NG tube, so it is false that they will be placed on a mechanical soft diet. So that is not acceptable for an answer for this type of question. So number 6 is false, so we won't use that one. Number 7, the patient is going to be on an NG tube. Are they going to be drinking lots of water?
No.
No, they're not. And even if they did drink a lot of water, they're not going to be moving the stool because they're coming in for an obstruction and they can't move that stool anyway. So the more water this patient drinks, the more the chances that they're probably going to throw up. So if they've got the NG tube in, that's why we put it in there to decompress that bowel to try to get the patient to relieve that obstruction. Number 8, I think y'all kind of all figured that one out. However, I just want to make sure everyone understands that the reason you see diarrhea and you're having stool is because you could have stool, but you're constipated. So diarrhea is not a sign you're passing stool adequately, because it could be a patient could be impacted and have diarrhea, because remember, with that big impaction of stool in the lower sigmoid colon, fluid can actually leak out around the hard stool and it appears to be diarrhea. So the only 2 answers is 1 and 2. Everybody understand that? I just want to make sure you understand the rationales for that question.
Yes.
All good? Give yourself a big applause. Y'all did pretty good on that one. All right. There you go. All right. Speaking of fecal impaction, let's talk about fecal impaction. Okay. We do know from your studies that fecal impaction is that hard removable mass of stool. And as we just said, there can be oozing around the fecal material that appears to be diarrhea, but it's not really diarrhea. So we have to do a rectal check on these patients. They might have some abdominal distension. They might have some very much rectal or abdominal discomfort. Obviously, things are all impacted. They may be feeling like they're sitting on something, okay, because their colon is kind of swollen up with all this stool. And fever can be present, because with bowel problems, fever can also be present with a fecal impaction. Doesn't necessarily have to be a high fever, but think about the older patient. The older patient can really be sick and have a fever even if they have a temperature of 97 or 98. They could really be sick because their temperature regulators are not working appropriately. All right. The diagnosis for fecal impaction, of course, is going to be a physical exam. Right. So that's and remember, with a digital inspection or removals, particularly with a removal, we have to have a healthcare provider's order to remove any fecal impaction. So for nursing interventions, a lot of times the doctor will order an oil retention enema to try to soften the stool and help it come out. Again, if the agency does say it's okay, or if the healthcare provider has written an order, we can remove it digitally. Be careful with the use of digital removal. Why? What are you going to be assessing frequently as you are doing this digital removal?
Be careful for the vagal nerve, maybe?
Yeah, so what, very good. So what are you going to be assessing constantly?
Blood pressure.
Okay. What's the first thing that you're going to notice?
Heart rate decrease.
Yes, pulse rate will decrease. Absolutely. So we don't want that vagus to be stimulated, which is going to cause a decrease in pulse rate, right? Older patients, there have been many situations in which an older patient was straining at a bowel movement and they actually have a heart attack because their pulse dropped too low. And it could also happen if you are removing a fecal impaction. So there's much more to be doing than just removing the stool and putting it into a bedpan and disposing of it. It's a dangerous thing to do, so be very, very careful in how you do that, and always be assessing your patient. All right. Okay. We can break it up, of course, manually and remove it. Sometimes the healthcare provider will order some, say, hydrogen peroxide to go through a rectal tube. Maybe we'll put in a rectal tube and put in like 50 mLs of hydrogen peroxide because that foams up and helps to break up the stool as well. All right. Be sure to, when you are inserting your finger in a fecal impaction, be sure that you are very gentle with that because it's easy to perforate the colon, and you don't want to perforate the bowels for sure during the procedure. Avoid trauma and don't wear your patient out, because particularly if they have a large amount of impaction, it's tiring for the patient and it's uncomfortable. So take your time, let them relax in between some of the removal, right? So it's not a fast, and unfortunately this is it's going to take a long time to remove a really serious fecal impaction because of all these factors. All right, and we see this in our older patients. Right. Bowel incontinence, of course, is accidentally, having a bowel movement and maybe not being able to control the stool. The couple of reasons could be, remember the neurological changes. We've talked about that already, where the sphincters, which are innervated by the nerves, the muscle nerves are relaxed too much, and they don't have the strength to stay closed when they do have a an urge to go to the bathroom, and so sometimes they just have bowel incontinence. That can happen. The first thing you're going to do, though, check for that fecal impaction, particularly if they're having bowel incontinence, because it could be that the pressure of all the stool that's in their colon is causing a lot of discomfort and also causing some of that liquid to come out around the stool. So we want to make sure we don't need to disimpact this patient first. Okay. Other causes, of course, of bowel incontinence can be tumors and neuromuscular issues as well. All right. There's lots of things that we can do to help with bowel incontinence. If it is a permanent problem, we can use rectal tubes, rectal bags to try to help that. It's best if it's a serious condition, I would say, particularly if it's very, very liquidy kind of stool. Otherwise, we have to really be doing meticulous skin care always with our patients, perineal care, because the bowel can actually cause excoriation and breakdown of the skin tissue. All right, so bowel incontinence. Another one that could happen is acute appendicitis. However, it's really not as common in older adults as it is for the younger group. So if a patient does have appendicitis, because it's not common, sometimes doctors will overlook the fact that it could be the appendix on that older person. So we have to really be watchful of that. It doesn't have the usual presentation of terrible pain like it would be for an acute exacerbation for a patient that's younger. There's very minimal or even absent pain. Now remember, the reason for that in the geriatric patient is what happens to the threshold of pain in the geriatric patient. Does it go up or down?
Down.
The threshold actually goes up. Because remember, we have this threshold, right? This patient can take so much pain, and as it goes up, they can take more pain without having much problems with it. So their pain threshold is going to go up. So they might not even realize they have pain, all right, because they can handle much more pain. So in this case, they may not even complain of any pain. And of course, you all know from appendicitis, if it becomes really, really bad and it can burst, it causes peritonitis and lots of problems, and actually can kill patients too if we don't catch it in time. And even for the older person, it's even worse because they have so much going against them in their changes in their body. So if they develop peritonitis as an older patient, they can die much faster than someone who and again, then who is younger. All right. A lot of times for acute appendicitis, as you know from treatment, it's usually to remove that appendix. All right. All right. Cancer of the pancreas. Unfortunately, with pancreas, you probably remember pancreatic cancer. We do see this in the older population. By the time it's diagnosed, with a lot of left upper pain, or what we feel maybe in the stomach. Patients will say it's in the stomach pain. By the time they start really noticing that, it's advanced cancer. The prognosis for pancreatitis is about 6 months. It's unfortunate. It's a rapid death with pancreatitis, although they have medications and stuff, but it's not a very good prognosis. Some of the later signs and symptoms of pancreatic cancer, of course, is going to be your weight loss and that pain, and they won't feel like eating. And of course, then you're going to show up with some jaundice from the liver, causing that to happen. And of course, they don't feel good. They feel sick. Anybody who has abdominal pain from pancreatitis or pancreatic cancer, they do better if they lean forward instead of lying back, because remember, it stretches the organ and the tissues around the organ, so it's a little bit more painful if they do that. So not a good thing to have. All right. So here's some signs and symptoms of pancreatic cancer. And as you can see, all of these are going to be true. All right. Anorexia, belching, nausea. All right. But again, by the time it's really detected and diagnosed, it's going to be a poor prognosis. And interesting enough, we kind of think about pancreatitis and pancreatic cancer with patients who drink a lot. That is not always the case, although there's a higher risk for patients who drink a lot of alcohol for pancreatic cancer, but there are people who don't drink alcohol and they still can develop pancreatic cancer. Right. It's probably one of the worst cancers there is because it's so rapid once they diagnose it. All right, for, of course, gallstones, cholelithiasis, pain really is the primary symptom. Where can the pain of gallstones be felt? There's two places. Where's the most common place that we might feel it?
Is it epigastric right side?
Yeah, that's kind of where we feel it. But you know, there's something called referred pain. And referred pain can go actually to the back, maybe in the middle of the back. We call that referred pain. So someone who has that pain could possibly have cholelithiasis. Sometimes it can radiate to the shoulder as well. So it doesn't always have to be in that right middle or upper abdominal area. It does increase with age, and obviously it makes sense. Gallstones, and remember, for gallstones, a lot of gallstones are formed by various crystals and minerals that we take in, similar to renal stones, and so we do see that as it increases with age, the older someone is. So the signs and symptoms, of course, is going to be some severe pain, discomfort, maybe some nausea. It's a pretty, I wouldn't call any surgery simple, but it's pretty fast surgery. Nowadays they do a laparotomy. In other words, go in, 3 little incisions, pop out that gallbladder. We just have to remember that with the gallbladder, we have to be able to teach our patient about the foods they eat and some things that they shouldn't eat, like the high fatty foods and stuff, because it's harder for them to digest it. Yeah. Cancer of the gallbladder is usually found in women, right? The signs and symptoms, of course, initially there's no pain, of course, and by the time, similar to the pancreas, by the time they discover that there's cancer of the gallbladder, there's going to be a very poor prognosis. Because it's so close to the liver, it tends to metastasize to the liver and to the pancreas. Stomach cancer does the same. It tends to go to the surrounding areas, so it'll go to like the pancreas, the stomach, from the stomach, the pancreas, the liver, because they're all kind of like stuck together there in the middle of the abdomen. When we think about breast cancer, we know that breast cancer tends to metastasize to the bone. So if you have a patient who's had breast cancer in the past, and now they're having severe bone pain, there's a good chance that metastasis has occurred from that. But we'll talk about the sexual reproductive system a little bit later on. All right. So in summary, for your digestive system, we do know that GI symptoms really need to be taken seriously. There are so many things that can cause GI symptoms. I mean, there really is, and sometimes doctors can't figure out what's going on until they do tons of tests. And it is very difficult to diagnose some of these tests, some of these conditions. So we need, as nurses, to be very careful when we assess our patient, making sure we document clearly and know how to assess the abdominal area, the esophagus, the upper esophagus and the mouth, and those types of things. So your assessment skills is definitely needed, particularly with the GI section. All right, any questions about that? All right. Oh, you did good in that one. So what I'm going to do is I'm going to switch over to, let's see if I can get off of here. I want to go to urinary elimination is the next one. I can't remember where it's at. I think it's this one. Yes. All right. Urinary elimination. It is chapter 21. All right. Mostly in urinary, we talk more about the incontinence and some kidney issues. All right. Fairly short. One thing I have for you, if you want to use it, I created like a word scramble kind of thing, and not a scramble, but a couple of, let me see what I call them. Terms to know. It's posted there on your canvas where you have to locate the terms to know. So be sure you know those terms. All right. And you can, if you feel like doing something like that, it's just something I threw in there for you. All right. So it's a little there. So the introduction to urinary, sometimes, and we know even from the commercials on TV, that thinking about urinary incontinence particularly is not really something that's the older adult likes to talk about a lot, because it can be embarrassing. They leak, they dribble, and so it's kind of uncomfortable. But because of that, sometimes the diagnostic or the diagnosis for any kind of urinary problems is missed or delayed, and treatment is going to be delayed if a patient has a problem. UTIs many times are delayed because the patient doesn't want to talk about having a pain on urination or lower abdominal pain. So we know that this is things that we do have to talk about. And of course, if a patient does have any type of incontinence with urine, or even urinary retention where they have to cath themselves, it will affect their lifestyle to some extent. And so it gives kind of a negative type of emotional feeling for many of our patients who have these problems, okay? So how does aging affect the urinary elimination? In this particular case, the bladder becomes hypertrophic. In other words, it actually thickens. The bladder thickens, whereas normally our muscles kind of atrophy a little bit, but in the bladder it's a little bit different. And because there's more thickened muscles, the amount of urine that the bladder can hold has definitely decreased. The bladder can't expand as much as it should be able to. So they tend to have to get to the bathroom much more frequently. As nurses, as a fairly young nurse, you can hold your urine probably 8-10 hours. But for an older person, that may not be the case. And sometimes it's a little frustrating for nurses who are constantly getting call lights because the patient's trying to go to the bathroom every 3 or maybe even 4 hours. But keep it in mind if you have an older patient, because it could really be their aging changes could be affecting their ability to urinate. So have patience with them. We've talked about nocturia. We do know that the renal function works better when the patient is lying down. So as soon as someone lies down at night, interesting enough, the kidneys work a lot better. So because of that, boop, out comes the urine and they have to go up to the bathroom. So we call that nocturia, because the vascularity around the renal and the kidneys functions better when the patient's kind of lying down, all right, instead of standing up or sitting up, okay? And again, for fecal impaction, we know that if a patient has a lot of fecal impaction, an older patient, what happens is that it puts pressure against the bladder. It can cause a lot of retention of urine. And men who retain lots of urine can also have what they call prostatic hypertrophy, all right, enlarged prostate, all right. So a couple of things to kind of remember here on the effects of aging is that we know from the aging experiences that the kidney tubules and the calyxes and all do not work as well in the older patient. In other words, it also has a problem with eliminating drugs because the kidneys don't work as much as they should. And it does have a problem with drug clearance or getting that drug out of the patient's body. They tend to also have higher blood urea and nitrogen levels because of the reduced ability of the kidneys to function. Again, we've mentioned the tubes, all right? So the normal age-related changes, again, frequency, nocturia, there sometimes is a prolonged effect of diuretic medications. Sodium regulation, of course, is difficult because the inability to dilute or concentrate the urine. So what we want to do is to help our patients have better urinary elimination. So how we do that? Well, we want a good fluid intake. Remember that fluid intake we talk about all the time? Vitamin C foods helps because it acidifies the urine, and bacteria doesn't like to grow in urine if it's real acidic, so that could help. Vitamin C rich foods. However, keep in mind that urinary incontinence is really not a normal finding for the older person, and generally there is a reason for urinary incontinence. It's not just something that's going to happen. There can be some issues, but just the incontinence itself is not normal. We don't like to see that. So there must be an underlying cause. And again, the cause could simply be neurological, muscle issues. It could be tumors. It could be a lot of other things, but it is truly not a normal finding, incontinence. And usually there is a treatable cause. Now, urinary retention, keep in mind, is really often found in males with benign prostatic hypertrophy. So they tend to keep urine in their bladder because, of course, the prostate swells up and it puts pressure on the ureters, and then the patient can't, the male has trouble voiding. They tend to dribble a little bit instead of voiding completely. So for this question, urinary frequency is caused by normal age-related changes of hypertrophy of the bladder muscle and thickening of the bladder. The answer is obviously true. The frequency can go up, but not so much as incontinence. Incontinence is not normal. We need to find out why the patient is incontinent. Okay, for health promotion, there is an assessment guide 21-1 on page 309 for urinary function. You might want to write that down. It's page 309. It's an assessment guide, urinary function, so that would be something to think about. When we are assessing our patient, these are lots of things that we can talk about and ask about. We want to talk about the frequency, if they're continent or if they're incontinent. Are they having any kinds of problems? Are they retaining urine? Do they always have to go to the bathroom and they feel like they haven't emptied urine? Are they having any pain with urination, or even without urination? Is there any lower abdominal pain, which could possibly indicate infection? Urine, what does the urine look like? Looking at the lab values of the urine. Kind of remind if you have to analyze a urinary analysis or a urine analysis, be sure you kind of remember some of those things. All right. And of course, medications. We're always looking at medications. We're going to inspect and percuss, palpate the bladder for fullness, right? Or pain or any other abnormalities, of course, right? So besides looking at the frequency and the color and the character and the quantity of urine, we're also looking at how many times, if they are incontinent, how many times a day do they have this problem? How long between voiding times do they have to wait? Maybe they're having some retention. Lots of questions that we can ask our patients in urinary health promotion, of course, okay? And we have to help them with a urine sample. Sometimes we have to assist them to get a urinary sample, or we can teach them how to do that and then they can give us a sample, okay? There are things that we can do for incontinence, such as the Kegel exercises, checking on medications. We've already mentioned their toileting schedule. Do you remember the Crede method? What is the use of the Crede method? How is it related to urinary elimination?
Is it when you stop the stream in the middle of urination?
Not quite. Remember the Pillsbury Doughboy, right? You know that little commercial where if you take your fist and go underneath the navel and roll it down like a rolling pin, that's what we call the Crede method. It helps to push the urine out of the bladder. So we can teach our patients that they're sitting on the toilet to take both of their hands and kind of roll down underneath their belly button, we call it, for the patient, and it actually helps to empty that bladder. So that would be something we'd want to teach them. We don't like to use intermittent catheterization unless it's necessary. There are some patients who have neurological issues and they're not able to even void hardly at all. So sometimes our older patients wind up having to do some intermittent catheterization about every 6 hours. Generally, that's the norm. So they would have to cath every 6 hours, or maybe it's about every 6 hours, I would think, to do that. And so we would have to teach them how to do self-catheterization, right? Of course, mobility also helps in all of this urination, okay? If they need a bedside commode, well, we definitely want to make sure they have that so they don't fall. It's a safety issue as well when they're trying to rush over to the bathroom. So let's look at this urine color here. So what can be causing the color changes of this urine? What about the light yellow? What do you say? What would cause light yellow urine?
The patient's adequately hydrated.
Yeah, they might be having a lot of fluid, right? Because you'll notice too, the more liquids that you drink during the day, the more your urine becomes much lighter. So we want to be able to analyze that. If it's yellow or green brown, it could be a bile duct that's obstructed or jaundiced. But you know, we really look at urine as seeing like straw colored urine. That's what we kind of want to look at. So that yellow is an okay color. Even the amber is okay. The dark brown, what does that tell us? The tea colored, what could that be?
Dehydrated.
Yeah, very dehydrated, very concentrated urine, and that's when we would start doing that hydration assessment to see how much they're drinking. Okay, remember, there goes your thirst mechanism again, and it all goes back to some of the changes that occur with our older population. All right, what about red or rust colored? Red or rust colored. What can that indicate?
Kidney infection or like inflammation.
Okay, it could be blood. A rusty red color could be there's blood, and it can come from a very serious kidney infection because the internal mucosa of the bladder can become extremely irritated and can bleed easily. Or if it's really, really red, then it could be some type of issue with bladder cancer. So the dark red is not the one that we want to see, right? What is an orange color? What comes to mind when you think about orange urine? I don't have it up here, but
Dehydrated.
Certain medications.
Yes. What is one of the most common medication for orange urine, is particularly for females?
Oh, ASO standard.
Yeah, it's actually called phenazopyridine. Okay, it actually causes a lot of oranginess, and it's used. This particular medication is over the counter, and it's used to decrease or anesthetize the inner walls of the bladder, or I should say yeah, it would be the inner wall of the bladder, because it's painful to have a urinary UTI. And so if you see a patient that has orange urine, it's got to be that, or sometimes even bile itself can cause an orange colored urine. Very dark brown, I mean, very, very, very dark brown, almost like a chocolate color, could be cancer, and it also could be hematuria as well. So we need to be able to identify what happens. Why urine color, although as we think about it, oh, it's just a colored urine, but oh, it can tell us so much about what's going on in the patient's elimination. Yeah. All right. So what can be causing the strange smells of urine?
Like high ammonia levels.
Yes. High ammonia levels tend to indicate a couple things. What is that?
UTI.
Infection. Absolutely. Particularly infection. Or we might
improper functioning of the liver.
Possibly. What happens if urine stays out for long periods of time? How does a patient smell?
Bacteria grows.
Yeah, the bacteria begins to grow. Is that ammonia smell? Yeah, so if they're laying in their urine for long periods of time, or if they're using adult briefs and you smell that ammonia level, that means that patient has been lying there a long time. And you know, ammonia can be very caustic to the skin. And so, we need to do some meticulous care on our patients who are incontinent or wearing adult briefs. That's important. What kind of foods can change the smell of urine?
Asparagus.
Asparagus is the worst. I don't know if y'all has anybody ever experienced that? I'm just curious. All the time. I love asparagus myself.
Me too.
Oh, and it smells like an old musty cellar, doesn't it? It's like if you're in the basement of a house and it's old and musty. So we got to make sure that we teach our patients, if they eat a lot of asparagus, not to be freaking out because their urine smells kind of musty like a cellar. That's very common. It's interesting to see that. What happens with antibiotics? Can you smell antibiotics in the urine?
Sometimes.
Yeah, particularly IV antibiotics. You can really smell those if your patient is on an antibiotic. A lot of times you can actually detect that in just the smell of the urine. So it's not just foods that can cause the change of smell in the urine. All right. Of course, on the color, this is called clear urine. It's clear yellow. I don't see any cloudiness, which could indicate a potential infection. There's nothing floating around in it. So this, just by grossly looking at this urine, it looks pretty healthy. Yeah, looks like some healthy urine, well hydrated patient. Yeah. Let's talk a little, sorry, I went backwards. Talk a little bit about urinary incontinence. And again, it's not part of normal aging, as I said. That's so important to know. And it can be transient. It could happen from time to time, or it can be what we call established, or it's going to happen all the time for their patient. And of course, the related changes, as we talked about already, does increase the risk. So let's look at the types of each one of these. All right. Be sure you know these types. I think there's one more. There you go. All right. Stress, incontinence really comes from like weak pelvic muscles. Obesity also is a factor in stress incontinence. The urgency, which is spasms can occur. This could happen from UTIs. If you've ever had a UTI or know someone or even a patient who had a UTI and they had this urge all of a sudden to go to the bathroom. The prostate enlargement also can cause urgency. Diverticulitis as well. Any type of pelvic or bladder tumors can also affect and cause what we call urinary or urgency incontinence. Overflow, which means that there's so much urine that's inside the bladder. Sometimes it's because the bladder neck is obstructed that could cause it. Some medications like adrenergics and anticholinergics also can cause it. Calcium channel blockers can cause it, overflow. And if the bladder muscles fail to contract, too much urine accumulates in the bladder, and we call that overflow. All right. There's an involuntary loss because there's too much. Multiple sclerosis and cerebral cortex lesions can actually cause what we call neurogenic bladder. In other words, the patient doesn't realize that they have to void, and so it becomes an issue for them. And those are two of the major ones: cerebral cortex lesions and multiple sclerosis. For functional, generally we're talking about cognition, dementia. The patient doesn't really has enough independence to be able to toilet themselves. Sometimes if they're on sedation, patients can have functional. And one thing with sedation, it's functional incontinence, so it's going to be, they may not have it for long periods of time depending on what medications they're on. Inaccessible bathroom medications, inaccessible, if they can't get to the bathroom, it can cause functional urine incontinence as well. And anything that messes with their cognition, such as different medications, can cause functional incontinence. And then mixed is a term that it could be a variety of factors that can cause this condition. So make sure you know the different types. Okay. So which type of incontinence is caused by bladder neck obstructions and medications? You said stress, urgency, overflow, or neurogenic?
Overflow.
Absolutely. Overflow it is. Very good. Oh, I'm sorry, it didn't come. The answer is C. All right, overflow. Very good. Okay. I guess it didn't pop up. All right. So again, what are we going to assess for urinary incontinence? And I listed them all here for you. We've talked about most of this. But it's important to really talk to a patient about urinary incontinence every time you do a routine assessment on a patient. How are they doing? You know, what kind of medicines? And so I believe y'all are familiar with this type of assessment. Here's some more. You're going to be looking at all of these, like elimination patterns, of course, any types of symptoms, their diet. All right. I think the here where it says reactions to urinary incontinence, I think that's important. And sometimes we as nurses forget to talk about the psychosocial issues a patient might be having. So what is the emotional impact of having any type of incontinence or even retention? And have to catheterize themselves? What is that emotional impact? And if there's something that we can help relieve some of that anxiety and frustration as well. We want to think about that. This basically says the same thing, it's just in a different way. So really when we do see urinary incontinence, the healthcare provider, as well as ourselves, are actually looking at what's causing it, what's the type, and can it be fixed? That's the key. Can it be fixed? And we have to be very encouraging to our patients. All right. Here is a quick check for you. A client requires behavioral therapies to decrease or eliminate urinary incontinence. Which procedure would the nurse expect to include in the teaching plan for this client? And you select all that apply. Think about that for a sec. Be sure you read the question carefully. What kind of behavioral therapies? Are you ready? I'm just going to ask someone to answer this. I don't want to put you on the spot. This is a little interesting to have to do. Anybody want to take this one?
I'd say number 1, Kegel exercise, because it's behavioral.
Very good.
Number 2, scheduled voiding, also behavioral.
Perfect.
And probably biofeedback.
Okay. Let me see if I put I thought I put the answers on here. I did. Any more? Are you good with that answer? I just asked.
Scheduled voiding as well.
Okay. Scheduled voiding and biofeedback. Let's look at the others. External catheters and self-catheterization are used to collect urine. It is not a behavioral therapy. So the key is the word behavioral therapy. So your external catheters and helping a patient self-catheterize is collecting urine. The post-void residual monitoring assesses the ability of the bladder to empty, but it doesn't decrease or eliminate the problem of urinary incontinence. Does everybody understand that and okay with that? So make sure you mark your paper there with those answers. Any questions? We just have a couple of slides and I'm going to finish these and then we're going to be finished with this short chapter and then we'll take our break. And there's all of your rationales. All right. Bladder cancer, of course, we've talked about some of this cancer thing. So again, chronic irritation of the bladder, lots of UTI, cigarette smoking, anything that can cause irritation can, increase the risk of bladder cancer. And it does increase with age, right? Signs and symptoms would be painless hematuria, just like everything else, it's painless. But if somebody has blood in their urine, it has to be investigated, right? All right. Treatment can be lots of things. It could be surgery, it could be chemotherapy, medications, those types of things. Now, metastasis, usually it's in the back or pelvic. So if a patient has got advanced bladder cancer, they will tend to feel that metastasis because it's going to go from the bladder to the lower back. Think about anatomical, where is the bladder located? And so it can also cause pelvic pain as well. If a patient has bladder cancer, it can also metastasize to the male prostate or vice versa because they're so close together. That's where we see a lot of the metastasis for bladder cancer. Renal calculi, there's lots of reasons for developing stone formations. If the patient doesn't get up and move around a lot, doesn't drink enough fluids, like such as dehydration or even hypercalcemia, because many of the renal stones are made of calcium that could cause renal calculi. We do know that there's pain and hematuria, UTIs, usually associated with renal calculi, and generally severe pain in the back. All right, can also be definitely a sign. So what we can do as nurses? Well, we want to give them lots of fluids, and healthcare providers, they do a lot of things. They might try to go in and pull out the stone, which is difficult, but they can do that. It's painful. There's lithotripsy, which they can do, which is sound waves that can break up the calculi, and then the patients will excrete those. But for us nurses, we want to be sure that we are keeping that urine fluid. The other thing with renal calculi, do remember that we might have to strain the urine for any, particularly if the patient is going to pass those stones. We teach them how to use the little strainer. And that's all part, I think you learn that in med-surg as well. The last condition here is glomerulonephritis. The symptoms for pyelonephritis is the same for both old and young people. Fever, fatigue, and the fevers could be quite high, 103 degrees. I've seen patients with very, very high fevers. They have pain in their back, of course, nausea and vomiting. They just don't feel well. So they have, and also pyelonephritis is very similar. Right. So usually the antibiotics help and those things. So very simplistic discussion there. Okay. So basically the things that we've already talked about, we need to be very sensitive with these patients, talking with them, think about how they feel. Do they have any anxiety? We want to do a lot of education for our patients. And of course, be discreet, all right, and help to maintain their dignity. That's a real key. That's a general consideration for most conditions anyway, but particularly for the urinary, because that seems to be a big concern for many of our older adults particularly. All right, do you have any questions? That's all we're going to talk about in urinary elimination. Okay, again, there's that little, I don't know what you call it. It's you have the names of the incontinence and you have to word search. Maybe that's what it's called. I forget what it's called, but I made that for you just for you to do something. But please be sure you know those definitions, okay, in the word search. And it's there for you. All right. All right, boy, it's 11:11 already. So let's see, come back at about 11:25. Oh, 11:30. I'm going to give you a few extra minutes. 11:30, and then we're going to start in one of my most favorite discussions of respiratory and circulatory system. Those are big chapters. We're going to do lots of discussion in those chapters. All right, so I'll see you back here at 11:30.
Thank you.
Oh, yes, thank you. And enjoy your break. You need to stretch a little bit and get a snack or something.